Good evening, and thank you for joining the Diabetes Research Institute Foundation for this very special occasion. My name is Sharon Kramer. I am the CEO of the Diabetes Research Institute Foundation, and I am someone who is living with type 1 diabetes myself. And unfortunately, I'm a fourth generation person in my family being affected by this disease, as I know many of you are on the call as well. So tonight, we are very fortunate to hear directly from the source about the study done by the CDC that links COVID-19 to diabetes. And perhaps that's why we have a worldwide audience tonight, from Bangladesh to New Zealand, Taiwan, and Italy. If you've tuned in, you'll hopefully get some valuable information from this dialogue tonight. We are incredibly excited. Just a brief overview of the DRI and of the foundation. The Diabetes Research Institute leads the world in cure-focused diabetes research. As one of the largest and most comprehensive research centers dedicated to curing diabetes, the DRI is aggressively working to develop a biological cure for diabetes by restoring natural insulin production and normalizing blood sugar levels without imposing other risks. The mission of the Diabetes Research Institute Foundation is to provide the Diabetes Research Institute with the funding necessary to cure diabetes now. We thank you for the critical role that you play in curing this disease. And the groundbreaking work at the DRI and beyond would not be possible without supporters and donors like yourselves. So thank you. So just a brief overview of the session and the format that's happening this evening. You're going to hear from Dr. Sharon Saydah of the CDC about the study conducted by the CDC, and also from Dr. Skyler from the DRI about what this could mean to the diabetes community and the mission of the DRIF. Each scientist will have time to discuss their area of expertise and then have a dialogue about what the public should know about the study and how this impacts the field of diabetes cure research and the diabetes community as a whole. We have received your questions in advance and pared down to a few that the majority have asked. If we're not able to get to your questions during the allotted time, please contact a member of the DRIF team and we will get back to you over the next week. The session is being recorded tonight and will be released at a later date for you to share with friends or any of those who could not join us this evening. So I now have the honor of introducing our speakers for tonight. Dr. Sharon Saydah is an epidemiologist and senior scientist at the U.S. Centers for Disease Control and Prevention, Division of Viral Diseases, Respiratory Viruses Branch, and commander in the United States Public Health Service. Prior to COVID-19 pandemic, CDR Saydah's work focused public health research on surveillance of diabetes among youth and young adults, along with the prevention of diabetes and its complications. She is currently deputy team lead for the Applied Epidemiological Studies team in the Respiratory Viruses Branch, leading research on the natural history of SARS-CoV-2 infection, and serves on the CDC COVID-19 response epidemiology task force as the co-lead for the post-COVID conditions. And I would also like to introduce Dr. Skyler, who is currently a professor of medicine, pediatrics, and psychology in the Division of Endocrinology, Diabetes, and Metabolism at the University of Miami Leonard M. Miller School of Medicine in Miami, Florida. He is the Deputy Director for Clinical Research and Academic Programs at the Diabetes Research Institute, University of Miami, where he previously was area leader for immunomodulation and tolerance. Dr. Skyler currently is chair of the Strategy Advisory Group for Anodia, a European consortium of academic and industry groups developing innovative approaches towards understanding and arresting type 1 diabetes. And he recently celebrated 46 years at the University of Miami. So let's begin with Dr. Saydah and the study done by the CDC. So Sharon, please take it away.
Great, thank you. I'm gonna share my screen and show some slides that hopefully will help our discussion. Can everyone see this? And I'll put this into slideshow. There we go, great. All right, thank you very much for inviting me here to speak with you tonight. I'm going to talk about whether or not there's a link between COVID-19 and diabetes. So to begin, we know that there's strong evidence that diabetes can increase the risk of severe COVID-19 in people. So hospitalizations, there's a 6-time higher increased risk of hospitalizations among individuals and a 12 times higher rate of COVID-19 among patients who report any of these underlying conditions, which diabetes is one of the main ones. What is really less clear is whether or not acute COVID-19 or COVID-19 treatments can lead to new diabetes either at the time of illness or after the acute phase of COVID-19. This figure depicts some possible mechanisms that might be going on. The first is stress hyperglycemia. So there might be an increase in release of inflammation mediators or an increase in glucose production. There's also a possibility that SARS-CoV-2 virus itself, which binds to the ACE2 receptors in pancreatic cells, can lead to beta cell destruction or dysfunction, which may increase hyperglycemia and possibly lead to diabetes. There's the use of in-hospital steroids, which can increase hyperglycemia during treatment. And then there's pre-existing diabetes, which may be unmasked during COVID-19 illness, also related to obesity, and then pre-diabetes may also be influenced by COVID-19. There have been a number of studies recently looking at diabetes among adults. So these have found that post-syndrome, which we consider post-COVID syndrome or post-COVID conditions to be occurring at least 4 weeks after acute COVID-19 illness. In studies in the UK, they found that there's 50% more likely to have diabetes in the 20 weeks after hospital discharge compared to the general population without COVID-19, or 296% more likely to have newly diagnosed type 2 diabetes, also compared to the general population, and also an increased risk compared to those with pneumonia. And then in the US, the VA data has also found 39% higher likelihood of diabetes among those with COVID-19 compared to those without COVID-19. But the pandemic did not only affect adults, it affected everyone, especially children. We recently published an article highlighting that during the pandemic, body mass index and obesity really increased among children and adolescents during this time, possibly predisposing them to risk for diabetes. There have also been a number of studies that have highlighted the incidence of increase in diabetes risk, especially type 1 diabetes, for those who had COVID-19, and the increased risk of diabetes ketoacidosis after COVID-19 infection. But to one of these points, this figure really illustrates that there is observed an increased incidence in, in type 1 diabetes among children and adolescents. So this figure here, the orange line, is the actual type 1 diabetes incidence from 2015 up through the pandemic, which is at the blue line to 2020, which we all realize. And then the line in gray is what we would forecast happening. And you can see that the orange line continues much higher and elevated compared to what is forecasted. So there does appear to be a larger than expected increase in incidence of type 1 diabetes since the pandemic. So at CDC, starting in the summer and fall of 2021, we started hearing reports of increases of newly diagnosed diabetes among children and adolescents. And so we wanted to investigate this. And one question that our investigation highlighted was whether or not these reports of increase in diabetes were due to COVID-19 illness itself, or whether they were occurring after SARS-CoV-2 infection. So we recently published this MMWR in the beginning of January that looked at this question. And these next slides, I'm gonna go through some of our findings in more detail. So to investigate this, we used retrospective cohort of patients less than 18 years of age from 2 electronic health data sources, IQVIA and Severity. And these are large commercial claim data sources. We compared children and adolescents with COVID-19 to those without COVID-19 during the pandemic period, and then also included a control group in the pre-pandemic period of those who had acute respiratory infection during that time. And you can see from this figure that we required that there would be no evidence of pre-existing diabetes in the year prior to our follow-up to aim to look for incident diabetes, with the idea that especially children and adolescents, we'd expect there to be at least one visit for diabetes during that time period. So this first table is highlighting the characteristics of our IQVIA pediatric cohort. So the columns in blue are of the COVID-19 or the pandemic period, so COVID-19 and non-COVID-19 group. And then the figures in yellow are our pre-pandemic period. So ARI is acute respiratory infection, and then non-ARI. So I want to highlight a few points here. First was that youth with COVID-19 were more likely to be hospitalized compared to those who did not have COVID-19 in this cohort. And I think importantly, DKA was much more common among youth with COVID-19 at the time of new diabetes diagnosis, close to 50% of them, compared to only 13% of those without COVID-19, but who were newly diagnosed with diabetes. For our health severity cohort, we saw a slightly different picture here. In this one, we found that the non-COVID-19 group had a higher rate of hospitalizations than the COVID-19 group. But still, we found that DKA at time of diagnosis was much higher in those with COVID-19 compared to those without COVID-19. We found that the incidence of diabetes, newly diagnosed diabetes, was much higher for children and adolescents with COVID at 316 per 100,000 compared to 118 in the non-COVID group, and also higher than what we observed in the pre-pandemic period of 126 for those with acute respiratory illness, and about the same for those without acute respiratory illness. And we found similar estimates when we looked at the health severity cohort, with elevated incidence among those children and adolescents who had COVID-19 compared to those without COVID. So this figure here shows our hazard ratios, and so this includes accounting for patient time in our analysis. And we found an increased risk for diabetes in children with COVID-19 compared to those either without COVID-19 or with acute respiratory illness. And so the first set of results here at the top are COVID-19 compared to non-COVID-19 in our pandemic period. And then the next group is COVID-19 compared to the pre-pandemic period. And then we included this last group just for our reference to see among youth, children and adolescents who had acute respiratory infections, were we seeing any increased risk for diabetes in the pre-pandemic period? And we did not see any association in that group. And we saw fairly similar results by the age groups and for both males and females. This is showing the hazard ratios for the health severity cohort. And here we found that the diabetes incidence was about 31% higher among youth with COVID-19 compared to those without COVID-19. We didn't see a significant association in diabetes among the children less than 12 years of age, but we did observe it for the other groups. And we tested to see whether or not there was an interaction between age group and sex, but they were not statistically significant. So we observed that children and adolescents younger than 18 with prior COVID-19 were up to 2.5 times more likely to be newly diagnosed with diabetes in the months following infection compared to those without COVID-19 or with other respiratory infections. And what is, I think, concerning for all of us is that at the time of diagnosis, nearly half of these children had DKA. There's clearly additional data needed to understand the underlying pathological mechanism and whether or not diabetes is either caused by the SARS-CoV-2 infection itself or results from treatment of COVID-19, and even whether or not the associated diabetes diagnosis is transient or is leading to a chronic condition. And I want to reiterate that we've seen similar results among adults. So adults who've tested positive for SARS-CoV-2 were almost 2 times more likely to develop type 2 diabetes compared to those who did not test positive or did not have a COVID-19 diagnosis. And among adults, we see that this risk increases with the severity of the SARS-CoV-2 infection. So it's higher among those hospitalized or those who were in intensive care. So a few take-home messages for everyone to think about. The first is that we do observe this increased risk of diabetes in the 30 days or more after COVID-19 diagnosis for adults, children, and adolescents. This really does highlight the importance of COVID-19 prevention strategies, including vaccination for all eligible people. Importantly, it also highlights the importance of chronic disease prevention and management on an ongoing basis. We do need to understand more about the mechanism of SARS-CoV-2 and how it might lead to incident diabetes, and also how this could differ between type 1 and type 2 diabetes. Since our analysis, we combined them, we did not focus on only type 1 or only type 2. And for anyone who's had SARS-CoV-2 infection, it's important to continue to monitor for long-term consequences, including the signs and symptoms of newly diagnosed diabetes or new diabetes. So, thank you. And with that, I will stop sharing. How do I do that? How do I stop now? Sorry.
Before we go over to Dr. Skyler,
oh, okay.
I wanted to just ask a quick question. Something came up through the questions themselves, and that is there a correlation between the severity of COVID symptoms and an increase in T1D children, or is any infection, either mild to severe, creating the problem?
So we did see that children who were in a separate analysis I didn't present here, but we did find that children who were hospitalized with COVID-19 had a higher risk of diabetes compared to children who are not hospitalized. So that would suggest that severity of initial symptoms corresponds to risk.
Great, thanks. Well, somebody that obviously is living with diabetes myself, you couldn't escape the news reports every day where they talk about the comorbidities of diabetes, asthma, and obesity. So this information is stunning, shocking, and really necessary to get out to the public. So appreciate you doing that. So I think now we'd like to hear from Dr. Skyler on the relevance to diabetes specifically, and what this could mean for people like myself and everybody on the call that are living with diabetes, or certainly at greater risk for developing T1D. So Dr. Skyler.
Thank you, Sean and Sharon. That was really great to hear that. The real issue, and Sharon highlighted it, is we're not sure of all the mechanisms that are going on. We know there is a clear, unambiguous association between COVID and diabetes. We know that people with diabetes have more severe problems with COVID, and that COVID has been associated with a greater likelihood of diabetes in the population. Those things are clear. What we don't know is why, and although Sharon pointed out a few potential things, that's really what I want to address in here. And my focus has always been on type 1 diabetes, but you can lump it together. because some of these things apply in type 2 as well. Early in the pandemic in 2020, there was this commentary that appeared in Diabetes Care, which is one of the professional journals of the American Diabetes Association. And it basically is summarized by saying COVID-19 in children with diabetes, updates, unknown, and next steps. And the first thing they said was do no extrapolation, because we really are not entirely clear. And the commentary said that the data are conflicting and inconclusive. And I'll talk about that in a second. Exposures to the viruses that may trigger type 1 diabetes that we've talked about historically. We talk about the virus potentially being a precipitating factor in initiating the autoimmunity of type 1 diabetes, but those exposures generally predate the onset of the disease by months to years. So you're exposed to a virus early in life, and then years later is when the diabetes appears. And so the fact that this is occurring concomitant with the actual COVID infection says that it's not the typical mechanism that we usually associate with the development of autoimmune type 1 diabetes. And so that's one thing that has led to some of the confusion and the unknowns about this. We also know that stress may influence the rates of new onset disease by changing the risk of developing autoimmunity. And the only certainty in the pandemic is that continued uncertainty exists about the course of the pandemic. And that's actually still the case because we're still mutating and finding out new things all the time. So, let me point out about the conflicting and inconclusive data for a moment. Sharon pointed out that one of the potential mechanisms by which COVID could induce diabetes was interacting with the ACE receptor, where the ACE receptor is a receptor, angiotensin converting enzyme receptor, which is on a number of cells. And the question is it on beta cells that make insulin? And could the virus be directly entering the beta cells because they have ACE receptors? And that there have been now at least 6 papers that have come out, 4 of which say, nope, the beta cells don't have ACE receptors. It's other cells within the pancreas that have the ACE receptors. And 2 of the other papers say, absolutely, the ACE receptors are on the beta cells. And so that's the basis of a portion of the controversy that exists, because each of the groups that have said this are well-recognized people who study beta cells and mechanisms of developing diabetes. And so there is conflicting information and therefore potentially a bit of confusion that exists out there. But even if the COVID does not enter the beta cells per se, by entering the cells in the pancreas around it, if that's where the ACE receptors are, that can create the stress response from those cells that can, in fact, impact locally the beta cells as well. So it's a bit complicated. We're not sure of all of the answers. And as I say, the data are conflicting, and that leads to some of the issue. So what do we see? Why do we see associations with virus and diabetes in general? Well, there can be a causal effect directly due to infection of beta cells. And a classic case of that was reported many years ago in the New England Journal of Medicine, where virus was actually isolated from the pancreas and shown to produce diabetes in animals. We think that is a relatively rare way that diabetes occurs, where the virus causes an infection that overwhelms the body and in the cases that have been examined, often kills the patient. As I say, that's a relatively rare way of seeing things. Although there is a form of diabetes that we see in East Asia, in Japan and Korea, and some parts of China that has been called fulminant type 1 diabetes, which we think may be induced by an acute viral infection as well. Second potential way is the causal effect is by altering immune function and the environment and initiating an immune response that eventuates several months to years later, usually years, in the development of type 1 diabetes. There is also a general susceptibility to infection in people with uncontrolled diabetes. That's not a causal effect, but that's there, and people who may be evolving diabetes and have higher than normal blood sugars may have more infection, and that may push them over from prediabetes to diabetes. And the stress of viral infection can precipitate high glucoses, which can lead to the diagnosis. So there's a lot of ways that that viruses can be associated with diabetes. And clearly, as Sharon pointed out, there is an association between COVID infection and more diabetes. And there's also the reciprocal of that. There's an association between diabetes, particularly uncontrolled diabetes, and worse COVID infections. So, you know, that's the circumstances that we are dealing with. Just to point out to you about the infections and things occurring later, this just shows you that a paper that appeared in JAMA in 2016 from Germany, that viral respiratory infections during the first 6 months of life were associated with type 1 diabetes development by age 8. So you had the infection early in life, but you didn't get the diabetes until a dramatic increase until the ages of 6 to 8 or so. So it doesn't occur right away in usual circumstances. That's why, you know, most of us are concerned that this is not COVID precipitating the typical autoimmune type 1 diabetes, but rather is causing the appearance of diabetes for one of those other reasons. And here are environmental factors which are associated with initiation or protection from IA's islet autoimmunity and progression to type 1 diabetes. And what we find is that some of the things that are involved, and I've highlighted them on the top, in things that may initiate the autoimmunity, maternal enterovirus infection during pregnancy is one that we particularly know exists because mothers whose babies have congenital rubella, we don't get much of that anymore because now we have rubella vaccines, but we used to see it, and it turned out that 30% of the babies who had congenital rubella also developed type 1 diabetes. So very high frequency. And that we think was because the mother was exposed in utero, and there's a proclivity for the rubella virus to potentially impact on the beta cells in the pancreas. Second one in the middle column is postnatal, that enterovirus infection, and particularly if there's a high viral load, and particularly if it's respiratory, have been shown to be potential precipitators of initiating the autoimmunity. And that resulted, as I showed you in the previous slide, in diabetes a number of years later. And lastly, in terms of postnatal progression to type 1 diabetes, persistent or recurrent enterovirus infections. And that has led to the notion that we might be able to develop a treatment for that, either by using an antiviral or by a vaccine to try to prevent the persistent recurrent enterovirus infection. And that's being evaluated at the current time. So I should point out that the stages of COVID-19 infection, the viral phase, people are asymptomatic 80% of the time. It's only 20% of the time that they have issues. And those things are hyperresponsiveness of the immune system, which might trigger diabetes if the immune system turns against the beta cells, hypercoagulability, and organ injury and failure. And some of those things can be quite severe, and that's what's resulted in the hospitalizations and the deaths, and is the reason that all of us advocate that everyone get vaccinated and get children vaccinated. Anybody for whom the vaccines are approved and for whom boosters are approved, it really does help to get those things so that if you do get it, you will remain asymptomatic or only have mild symptoms. This is just to show you a cartoon of the ACE receptor that I was talking about, and the portion of it there that is on there and that can bind the virus. And this just points out that the ACE2 receptor is known to occur in the ducts and the acinar tissue, the portions, and in capillaries in the pancreas. Whether they are in the islets or not is the debated thing, but they certainly do occur in other parts of the pancreas. So those are the only slides I wanted to show you, and those are the main points that I wanted to make. They're sort of complementary to what Sharon just said. And Sean, we'll turn it back to you so you can turn the questions that you have retrieved over to Sharon and I to try to see if we can make sense of them.
Great. Thank you, Dr. Skyler. Really phenomenal topic and presentation. So I want to thank you both. We did get some really great questions. So the first question goes to Dr. Saydah. Do you have any advice or suggestions for parents of children that are either currently living with or at greater risk of developing T1D? And then are there any additional measures that they should take, especially now as we're seeing the mask mandates and other measures to kind of control the virus itself are starting to loosen up?
Yeah, those are great questions. And I think that in terms of preventing COVID-19, continuing to advocate for vaccination for anyone who's eligible is really important. And then doing what you can to protect yourself. So masks definitely offer another layer of protection, along with basic hygiene, distance. If you're home, if you're sick, stay home. Don't go out if you're not feeling well. Things like that. In terms of for children who might be at higher risk for diabetes, I think one thing that we found is important is just for parents to really be aware of the signs and symptoms of diabetes and make sure that they get their kids to a healthcare provider or a treatment as needed. And because we've seen more children in general, whether or not they've had COVID-19 infections, presenting in DKA, which can be a very serious complication, it's important to really be aware of those signs and symptoms. So increased thirst, increased tiredness, increased going to the bathroom, urination, extreme weight loss, things like that.
Great, thank you. And I had every single one of those symptoms, unfortunately. Dr. Skyler, what are your thoughts in terms of the information that we have now from COVID and its impact at the DRI in terms of our cure-based research?
Well, it has a couple of things. One is that we had to slow down some of the things during COVID, particularly things that we would be doing that might involve immune intervention, because we used immunosuppression to try to delay the progress of type 1 diabetes or treat new onset diabetes. And we use immunosuppression when we're putting in cellular therapies for diabetes to prevent rejection. And by creating immune suppression, we increase the risk of COVID. And so therefore we had to shut much of that down during particularly during the early phases of COVID. And what our scientists did, though, instead was they tried to use some of the cells that they were creating to see if they could modify type 1 diabetes to say, okay, these things control inflammatory response and infection, and maybe these cells, mesenchymal stem cells, could be used to slow the course of COVID. And so they were given to people who were in the ICU on respirators with COVID and found that in a subset of those people, at least, it increased their survival. So we shifted the focus a little bit. Now we're using those same cells and we're going back and using them in diabetes and particularly in diabetic complications. So it's had some impact in slowing us down on some respects, but giving us some insights in how to use these cells in other respects. So, there've been pros and cons, just like with everything else.
Yeah, certainly. Thanks. And then just following up on that, are there any lessons or takeaways from early findings of our Poseidon study for COVID-19?
Yeah, Poseidon is using vitamin D and omega-3 fatty acids, which are anti-inflammatory. Whether they would be useful during COVID or not is not known.
Thanks, Dr. Scott. Dr. Saydah, there have been studies that are examining the link between COVID and both T1 and T2 diabetes. Do you have any information or data showing how COVID is impacting T2?
Yeah, so the study that I presented among kids, we combined both type 1 and type 2 diabetes together. But I will note that, we rarely see new cases of type 1 diabetes in children less than 12 years old. So the fact that we saw an increase in diabetes among the under 12-year group, probably most of that is likely to be type 1 diabetes. The studies in adults have primarily focused on type 2 diabetes, and so we see an increased risk with that. So it likely could be both. But I will just also add that, especially in the beginning, depending on how people present, sometimes, especially for kids and adolescents, determining or distinguishing between type 1 and type 2 diabetes can be really complicated.
And this could be for either of you. How does contracting COVID-19 affect blood sugar levels?
Well, as I said, any viral infection creates a stress on the body and raises blood sugar. And as does any bacterial infection, all infections create the stress and raise the blood sugar. And so patient needs to be vigilant and on top of things. And Sharon pointed out one other thing that may have been subtle and lost to the audience, which I would like to emphasize, is that one of the known treatments that helps control the COVID infection is corticosteroids. And corticosteroids, dexamethasone is the one that's been used in several of the studies, but prednisone, methylprednisolone, all those that are used, and they've all been tried to try to tamper down the COVID infection. All of them raise the blood sugar. And people on insulin may have doubling and even tripling of their doses of insulin to keep the blood sugar under control, because out of control blood sugar makes the COVID go worse. And so, it's a vicious cycle in there. And yet you need the steroids to try to control the virus, but you have to compensate for that by paying better attention to the glucose. So it is a complicated matter, and things go back and forth.
So Dr. Skyler, can you talk about some of the research that's currently being done at the DRI in terms of our cure-focused research?
Yeah, the things that we're trying to do are find a way to. We've been doing. My colleagues at DRI have been actually some of the pioneers in beta cell replacement using isolated islets, and isolated islets come from cadaver donors. People, I think the epidemiologist, Sharon can correct me if I'm wrong. The epidemiologist would say most of those cadaver donors are motorcycle accidents historically. I think that people who ride motorcycles should have a sign on the back of their motorcycle, future organ donor, but maybe I'm being overly critical. We gather those, and it actually turns out that of organ donors in the United States, only about 1,200 a year have pancreases available, suitable donors for pancreas that are harvested. And so even if we got 100% of those 1,200 a year, you're not going to be able to reverse a lot of diabetes with it. And the NIH had a clinical islet transplant consortium that Camillo Ricordi at DRI chaired, which was a group of centers across the country, which demonstrated that you actually do correct a number of metabolic abnormalities when you do islet transplantation, particularly people who've had recurrent severe hypoglycemia. And by severe, I use a definition that means they ended up either with a seizure or coma in an emergency room, or otherwise needing assistance from other people to be able to be corrected. And islet transplantation totally corrects that. And the people who were in the study were ones who were having several episodes in the past year or two of recurrent severe hypoglycemia. But as I said, the problem gets to be those cells are foreign cells, they're a donor. So therefore you need to have immunosuppression to prevent them from being rejected. Secondly, we only have 1,200 donors a year, and that won't go very far if you want to try to treat everybody with diabetes. And thirdly, historically, they've been put into the liver, which is a relatively hostile environment for cells because the liver tries to protect itself. And even though the liver is where they were put in the liver, because that's where the pancreas blood supply goes to the liver first before it goes to the rest of the body. And so it was a logical thing to do, but that means that the site that we've been giving them is not necessarily the best site. The sustainability of them with immunosuppression creates problems of its own. And the source of the cells, being cadaver donors, is limited. So a lot of the major effort that goes on at DRI is to create a new source of cells, a better way of sustaining those cells, and finding a site to put those cells that would not be as hostile. For the latter, we've done a number of patients now where the islets have been put into the omentum in the peritoneal cavity. 50% of the blood supply of the omentum does go directly to the liver. So that's similar to a blood supply from the pancreas, at least for half the blood supply. And those cells seem to survive reasonably well there. The sustainability is being addressed by trying to find forms of encapsulating the cells with a surrounding surface that gives them enough oxygen and provides protection from the immune system actually attacking the cells directly. And so a lot of progress being made in that direction. And for source of cells, we think that the source of cells will be some form of stem cell. And therefore, we're collaborating with a number of companies which have put into development a commercial source of basically an unlimited source of stem cells that can be differentiated to islets or beta cells that can make insulin, so that we would have a complete supply. If we can protect them well, we can sustain them. And if we put them in a site that isn't hostile for them, hopefully they'll do better and last longer. What we know so far is that there have been reports from two of the companies that make these cells already that show that the concept works in a limited number of patients so far, and with immunosuppression still. So that there's a number of steps that need to go along the way before we will get to having wide-scale use of stem cell replacement for treatment of diabetes. But my prediction is that in the long run, we will be able to use a beta cell replacement approach for everybody with type 1 diabetes and even potentially for type 2 diabetes, because although type 2 diabetes has multiple mechanisms, and people often focus on the insulin resistance, which is caused by the obesity and lack of physical activity. If you're obese and you're not physically active and you don't have diabetes, it means your beta cells are working. And so you only get the diabetes when the beta cells are also not working appropriately. So it could actually be helpful in type 2 as well. But that requires a lot more experimentation as well. So that's probably a very long-winded answer to your very short question, but I wanted to be sure that I gave you the complete picture.
I appreciate that. I know the audience appreciates it as well. I know there's a lot of work happening many, many researchers. So we have a question that came in that needs just a bit of clarification, Dr. Saydah. The question is, if new cases of type 1 are rare in children under 12, why are we recommending vaccinations?
No, she said type 2.
Two. Got it.
2 is rare.
Okay. Great. Wonderful. So just in terms of closing, I'll leave it to both of you if you have any last minute statements that you want to kind of make to the group, and then I'll close it out.
Well, I'll start by saying that I think the most important thing is that everybody who has diabetes, has a family member with diabetes, or is at risk of developing diabetes should be vaccinated. And there is absolutely no reason not to be vaccinated. You need it to protect you from the severity of the disease that's increased with diabetes, and the potential that if you have a family member that you'll get them infected and be worse. And so I just urge everybody, vaccines are crucial. We've got great vaccines. I think Operation Warp Speed was one of the most successful things our government has ever done. And we, in record time, were able to get vaccines. And, Alex Azar, who was the Secretary of Health during the time and led Operation Warp Speed, is now a professor at the business school at the University of Miami. And he said during a recent conference call or Zoom, a webinar on Zoom, it's hard to separate these things out these days, but he said, one of the things is that we in the health department were able to get companies working together and get the vaccines through. But we would have been totally hopeless if we didn't have the military to figure out the logistics of delivering the vaccine to the country at large. And so I think that, it was Operation Warp Speed was a really revolutionary kind of approach where the health people and the military people worked together and solved a critical problem and brought that vaccine out in record time. And I think, that is really a commendable achievement, and we need to take advantage of that, and everybody needs to be vaccinated.
Great. I would hope that we could muster that same effort across the globe to find a cure for type 1. Dr. Saydah?
I just really want to thank everyone here for inviting me. It's a great discussion, and this is an area where prior to COVID-19, all my research really did focus on diabetes in kids, and unfortunately, as I pivoted over to the COVID-19 response, but I found that this all came together, and so it's definitely an important topic.
Wonderful. Well, I want to thank both you, Dr. Saydah and Dr. Skyler. I hope that everyone enjoyed the program this evening or afternoon or morning, depending on where you are calling in from. We again thank you for the important role that you play in our mission to cure diabetes, especially during the COVID-19 pandemic. If you have a question that did not get answered this evening, or if you'd like more information on how to get involved, please contact a team member of the DRIF. I'd like to give a huge thank you to Sharon and the CDC team for their ease in working with us to deliver this program to you. And the incredible work being done both at the DRI and the CDC is truly life-saving. We hope this isn't the last time that you join us for these educational programs that are held virtually throughout the year. We want to thank everyone and hope you enjoy the rest of your evenings. Thank you all so much.